Right, it's a pleasure to invite Dr. Tze Tec Chong, also from Singapore, to talk about clinical outcomes of using non-compliant balloons for CLTI.
Good afternoon. Thank you, Dr. Manzi and P.I.N.N.A.C.L.E, Chairman and panelists, ladies and gentlemen. My name is Tze Tec Chong from Singapore, and I'm here to talk to you about the P.I.N.N.A.C.L.E study. As you can see, it's a really long name. It'll take me 2 minutes to read that, so I'll let you read it on your own. I'm from Singapore General Hospital. We're a large tertiary referral hospital in Singapore. Was initially putting up that we were more than 200 years old until I found out that the University of Padua is founded in 1222, so I stopped putting that in there. So the majority of patients we treat will be diabetic, has ESRF, and hypertension. Most of our patients, like the ones you see up on the screen, have mixed FEMPOP and BTK disease, and most of them have severe calcifications. In this group of patients, there are complex, long, and calcified lesions, and they respond poorly to angioplasty alone. We know that BMS, especially in the below-knee segment, is no superiority over POBA, and we generally subscribe to the leave nothing behind concept. So conventional balloon angioplasty is not the best in this kind of patient population, and we talked about wound healing as the best outcome, so ensuring good luminal gain is important in this group of patients. In line with that, good vessel preparation is highly important, as you have seen in all of the cases. And the use of these high-pressure, non-compliant balloons allows for the force to be uniformly distributed at the disease segment. In the top picture, you can see a semi-compliant balloon forced by the constricted area may lead to this dog bone effect. And this tends to advocate more high stress to both ends of the artery, may cause dissections and arterial injury. The non-compliant balloon, however, is more uniform distribution of this stress, even with these calcified plaques. The balloon they've used in the P.I.N.N.A.C.L study is this JADE non-compliant balloon. It happens to have a high burst pressure as well, but the unique feature of it is the non-compliant nature, not the high burst pressure. And there's this Z-tip technology that allows for easy passage into the lesion. I'm going to focus on 2 studies done in Singapore. The first one is initial one in 2016, where 20 patients with long 100 millimeters calcified lesions were enrolled, the usual smattering of comorbidities, and they all Rutherford 5 and 6 lesions with CLI-C and D. Results are shown here. Freedom from CDTLR at 12 months, 89%, 24 months, 78%, 36 months, 64%. Quite respectable for this group of patients with 57.5% tibial arteries, 42.5% inframalleolar arteries, severe calcification in 78%. More interestingly would be the percentage wound healing, achieving at 36 months, 85.7%. The second is a study from my group, including patients from Hong Kong as well, 86 CLTI patients with chronic renal impairment. As you saw in the case that Marco was doing, 75.6% of them have it. And the Rutherford score, again, 91% Rutherford 5, and the rest Rutherford 6. CLI-C and D lesions only, with 83.7% moderately to severely calcified lesions. So all of them had tibial arteries treated, and you can see the report is freedom from CDTLR at 12 months, 90.7%, complete wound healing at 88.1%. In univariate analysis, those patients with elastic recoil post-angioplasty are associated with worse 6 months outcome. So it's important not to have these kind of recoil, and vessel preparation is important. This leads to this study, the P.I.N.N.A.C.L study. In short, it's going to be on CLTI disease with CLI-C and D lesions using the JADE balloon. So the JADE balloon was used exclusively in these patients. There is no atherectomy, no semi-compliant balloon, and no DCB. So this is quite a clean sample of patients. The clinical primary endpoint will be freedom from MAE through 30 days. Performance primary endpoint will be freedom from CDTLR within 6 months. As mentioned, 50 patients recruited, typical inclusion and exclusion criteria. We did not include heel ulcer because I think in our experience, and probably yours as well, those ulcers will be very difficult to heal, and it may not be just a feature of revascularization. Patient demographics, we have these kind of patients, average age of 66 years old, not 87 like you've shown over here, with diabetes in 86% of the population, so pretty bad. In terms of medications, we heard from the talk in this morning that they need to be on aspirin and statins. Most of them are, 82% and 92% are, but we could improve on the diabetes medications. The Rutherford score is majority Rutherford 5 and above. In terms of the Wi-Fi classification, you can see over here the risk of amputation is 54% at moderate or high risk for amputation in this group of patients. For these 85 patients with 85 lesions, most of them are in the BTK vessel, 69.4% of the arteries, and the average lesion length is 23 centimeters. So really quite long lesions, much like what we see in the real world. This is the outcome, freedom from CDTLR 6 months at 91.7%, 12 months 87.5%, and the average time to CDTLR is 156 days. What's important to the patient is amputation-free survival. At 6 months, it's 84%, 12 months, 70%. When you think about the majority of patients at 54% were high risk for amputation, this is reasonable. Death, of course, is shown here. And in terms of the Rutherford score, most of them started at 5 at baseline, and then they progressed at 6 months and 12 months to most of them 0. So this is a clinically significant as well as a statistically significant difference. So at 12 months, 82.9% have a more than one category Rutherford improvement. And percentage of wounds healed at 6 months, 78.4%, and at 12 months, 90%. I'll go ahead and show you one case example, 83-year-old woman with diabetes, hypertension, hyperlipidemia. You can see she presented with right, second, and third toe wound. And over here, you can see the baseline characteristics of the BTK artery is really quite bad. And the treatment was with a long 3 by 240 millimeter jade balloon. We like the long lengths because it just decreases the amount of time we need for angioplasty and perhaps radiation as well. This patient obviously had a total knee replacement as well. And you can see that there was no significant recoil or residual stenosis after the treatment with improvement of the perfusion at the foot level. I don't have a dedicated foot shot in this presentation. And the final outcome was less than 30% residual stenosis. So in conclusion, this JADE high-pressure non-compliant balloon is safe and effective for the use in lower limb arteries and is really good to prepare the vessel also if you intend to use any adjuncts. We have a 70% amputation-free survival, 90% wound closure rate at 12 months. In this very challenging group of patients, 86% diabetics, 24% requiring dialysis, and 90% of these are Rutherford 5 and above, with a 54% chance of amputation based on Wi-Fi criteria, and about 70% in BTK disease. So these non-compliant balloons, due to their unique P.I.N.N.A.C.L.E material, allows for uniform pressure to be applied all throughout the artery and avoid overstretching of the other disease segments, and this could perhaps reduce the risk of dissection and prolong primary patency. Thank you very much for your attention.